At this time, I'd like to introduce our next guest speaker, Ron Chance. Ron serves as the Community Programs Manager at Dane County Department of Human Services, where he oversees the Joining Forces for Families initiative, one of the largest human services collaboratives in the United States. This neighborhood-based teaming approach involving a community social worker, school personnel, public health, law enforcement, and others has stabilized over 700 vulnerable families through resource linkage and case management strategies. Ron is also director of Dane County's Early Childhood Initiative, an innovative home visitation program with an intensive employment and training approach targeted at chronic poverty families. Prior to this, he was the first facilitator of the Northside Planning Council, a resident-led organization focused on community development, and project director of the National Youth Gang Project, sponsored by the U.S. Department of Justice and located at the University of Chicago. The National Youth Gang Project developed the Spurgle model, am I pronouncing that correctly? To assist communities in their efforts to address youth gang violence. Additionally, he has worked as an administrator in the nonprofit sector with the U.S. Peace Corps in Philadelphia and Washington, D.C. He served as a Peace Corps volunteer in the Kingdom of Nepal as a teacher. He has a master's degree from the School of Social Service Administration at the University of Chicago. And Mr. Chance was selected as the Outstanding Social Worker for the state of Wisconsin by the NASW in 2007. Please join me in welcoming Ron Chance.
All right, let me get set here. Just want to get an idea of who's in the audience. How many mental health therapists are in the audience right now? Social workers? Doctors? Anybody else? Pardon? Public health. Public health. We love public health in Madison. So anyway, I handed out a packet just so that I could go quickly in this presentation. The yellow sheet's an overview of the Dane County Early Childhood Initiative. The brochure is also in there for the program, a logic model describing the components of the model that we'll discuss, and then a couple of case studies of families that we helped with the initiative. I was thinking, how can I get your attention, at this conference? And so I thought I would start off by sharing some of my own personal mental health crises, to set some context. And I think actually one of the reasons why there's still a stigma, with regard to mental health issues is because professionals and highly successful people don't share their own challenges in their own lives. So I have two incidences in my personal life that kind of, I think, shed some light on things. One was when I was in midlife as a professional. I was a workaholic. I would be working at 11 o'clock on a Saturday night. And what I did basically is that I became exhausted and threw the biochemistry off in my body and started having anxiety attacks. So here I am, in the living room, my wife's up with me, and I said, honey, I think I'm having a heart attack, And she had just learned, she just got back on the road with her car. I bought her a Crown Victoria. She hadn't driven in 6 years. So here she is driving me to urgent care, in this big, massive automobile that she doesn't know how to drive. We pull up in the parking lot, and she can't park the car. And I said, honey, park the car. I'm dying here. I go in. I'm seen by a doctor. They say, well, you're not having a heart attack. You're fine. I go back, and I came back to urgent care about 3 times. And so I'm showing up in urgent care, and they're thinking that, here's this hypochondriac guy, coming to suck resources out of our system. Well, it took a long path. I was referred to a mental health therapist. That person handed me a book called The Anxiety Disease, which portrayed this long life struggle with mental health issues. I then saw a cognitive psychologist that gave me some behavioral techniques, and then I figured out on my own the 5 or 6 things that I needed to do, to make myself better, which was, spiritual dimension, physical exercise, and things of that nature. So here I am, an educated person. I'm a social worker. I have health insurance. I come into the system, and I have to figure it out myself. The second episode involves challenges with my daughter. Severe depression in high school, a lot of self-medication scenarios. 4 or 5 emergency room visits. I think the last most chronic episode was she had self-medicated. I was trying to keep her in the house because she was going to flee and I didn't know where she was going to go. She got out of the house. She was inappropriately clothed. I'm driving down the road with my window open saying, honey, I'm going to have to call the cops. Honey, I'm going to have to call the cops. And she kept on going, and I did call the cops. 2 female police officers showed up. They had been trained in mental health response and how to assess it, and we were able to de-escalate the situation and not have her be arrested. And she's doing great now. She got an appropriate diagnosis. She's got on meds that have stabilized her moods, and this fall she'll be going to Hong Kong to study at the Chinese University of Hong Kong. And so again, this issue of making sure that everybody's educated on the mental health issues and knows how to respond. Quickly, just to give some context here, from my vantage point as a social worker, there's some very severe things that are happening now that we're concerned about. First is the increasing poverty issue. I know Charles mentioned yesterday that there's like 45, 46 million people that were uninsured on health care. And I think the people in poverty, it's the same. About 48, 50 million people are now in poverty. We're seeing a lot of people in my work that we've never seen before. Lower middle class people falling down into the lower class, bombing out of their housing. We're seeing a lot of families with multiple challenges. We have a reduction in the services and resources in our community to assist them. We're seeing a subpopulation that has a nexus of aorta mental health, domestic violence, and trauma histories in play, and that's been very challenging for us. And so there's 2 questions that I think frame what I'm dealing with as a social worker and how to approach this issue. And it deals with services integration and collaboration and how do we work across systems, because we're siloed still, even with these innovative approaches. So the first question is, how do we structure ourselves as professionals to work effectively cross-system in teams? Because we have families with multiple challenges, and the way you're going to get resources to help them, they're still in silos. So how do you team effectively? How do you create that structure? And then what do we need to have in our toolkit to effectively engage families so that they'll keep on coming back so we can provide them services and improve our outcomes with them? And what I'll make the point in this presentation with regard to people without means is that increasingly we have to emphasize employment response, housing stability, keeping them stable in their households, educational linking strategies to get them educated and higher wages, and then this whole mental health aorta DV trauma thing. We need to be more effective in that response to have better outcomes. So as a social worker, my big question is, how do we array our services to attack poverty? Because poverty is increasing. And if you look at my system, we are spending millions and millions of dollars just to enforce court orders or to document demonstrated intent to keep families safe. And it's episodic. We're not doing anything to attack poverty, so we have these families keep on coming back in poverty, and it's intergenerational now. For mental health providers or mental health therapists, my question to you is, what is in your toolkit to mitigate the environmental pressures that are causing your clients to have negative mental health outcomes? Are you doing anything in collaboration to engage people, public health nurses, housing case managers, employment specialists, to actually try to have an impact on the environmental factors? Because what I'll say, and what a lot of the poverty research will say, is if you don't have a game plan in the community, your interventions will be overwhelmed by the environment in that community. So what I will present today is a model that we came up with to try to move on that issue. So this program was started by Kathleen Falk, County Executive Kathleen Falk. And usually when I've seen innovative programs come to pass, it's either a political leader in the center that's saying, we're going to do this, here's the funding, here's some support, go at it. Or there's a funding approach which specifies an integrated collaborative model. Or there's just line workers getting together and saying, hey, it's not working, let's do it on our own, let's figure it out. So with the Early Childhood Initiative, what we decided to do is we decided to do a geographic focus. We plotted our open caseloads for CPS and delinquency. We plotted the high poverty areas, and our first community was Allied Drive, a port of entry community for people coming from Milwaukee and Chicago. And also, we found that 8% of the people in poverty lived in like a 4-block area, so we started there. And then after we saw some success in Allied, we went to the other poverty communities and got early childhood teams on the ground. So what is ECI? It's just basically an early childhood approach designed to improve the life trajectories of infants and to help low-income poverty families. And then basically our target population is anybody prenatal or has a child under the age of 1. They have access to the early childhood approach, and we'll stay with them up to 3 years. And it's just not first-time mothers. We'll go with second-time mothers. We'll work the whole family on our agenda of intervention. So the service array is prenatal care, parenting education and family support, immunizations, preventive health care, mental health intervention related to postpartum depression, and then this benefit and basic needs resources, linkages to housing stability, and employment and training. What's crazy about current approaches across the country in early childhood is they haven't anticipated that if you're working with low-income people, you have to have an employment response, you have to get them connected to safety net resources, you have to be structured in a way where you can develop relationships with them, and you have to get them educational training to improve their situation. So the team is basically, we have family support specialists, generally masters in social work, people who do home visitation. We have a full-time employment specialist that works the whole family on an employment agenda. We have an economic support worker from our job center. This is the person that kind of gets people attached to safety net, MA food stamps. They work on the team. They're community-based with us. And the idea is we attach them to the safety net resources and we prevent the sanction hits from coming because that will destabilize the household. And then somebody to coordinate the program. Our partners are Dane County Human Services, an employment and training group, a couple of family child agencies, University of Wisconsin, School of Medicine, Department of Psychiatry, and the UW School of Social Work. Initially, we got a grant from a local foundation of $50,000, then we got a Wisconsin partnership grant of about $450,000 for 3 years, and then we demonstrated success, and the county executive picked it up in our budget to continue the model. So if you look at it, this is pretty much a full explication of our model. Who's on our teams, who our partners are, what activities we perform, and what we expect in terms of short-term and mid-term and long-term outcomes. And so you can see it's pretty full scope, and we're not only intervening with the family, but we're based in the community environment, and we're trying to work on a number of areas. Our budget's about $788,000, and our cost for family is about $98,500. Now, being in the field for a long time, there's two things that I found out, and I've talked to some people here about it, they already know it. The 20-80 rule. If you study human services population in different areas, 20% of your consumers consume 80% of your resources. But a lot of times they're not on our radar screen. In fact, when Hennepin County identified their 200 top most expensive families in 1997 and 1998, it was $200 million a year. And they found out that there was no coherent continuum of service. It was generally young mothers, episodic homelessness, severe depression, no employment skills, drug addiction, domestic violence. And when they looked at how we intervened with those families, it was anywhere from not giving them appropriate intervention at a given time to throwing in the kitchen sink. And so I think that one metric which would transform our system is if we started to attach cost to cases, because it'd make us more accountable, and then we'd have to really start to implement these collaborative models. So our target population, you can see it's primarily a person of color population. We have Spanish-speaking home visitors on our approach in each of the sites. The average age of the parents is 25. 3/4 of the parents are unmarried. Less than 1/3 are working full or part-time, and only half have a 12th grade education. We found that a lot of these people couldn't pass their GEDs. They weren't reading at the 9th grade level, and that's been a challenge for us, but we're trying to figure out ways which we can get them in apprenticeship training programs and combine the GED with the apprenticeship training program. We do a number of things to assess families related to depression and parent-child interaction. We videotape them. We have them watch the videotapes. We give them parenting support and parenting education. These are all validated instruments. One of the things we found was 60% of the focal caretakers in the families that we assessed were severely depressed. And that went against national figures, which it's about 30% in low-income areas. And so that was kind of shocking for us. And it made us beef up our mental health response. We have them formulate family plans. We have 22 goals and a number of objectives under those, and the concentration is physical, emotional health, child development, family stability, and healthy relationships. And also what we found over a period of time is that we have had statistically significant improvement in parent-infant relationships. We've had a decrease in depression scores, maternal depression, anxiety. We've increased job placements, and we've seen some increases in positive gains with child development. We've increased the rates of food security, and again, this employment thing has been in one of our key outcomes. So as of January 2012, we've found about 350 jobs for people, 183 full-time, 175 part-time. Reality is that what's happening with a lot of low-income people now, they're working 2 and 3 jobs to make it. And the new corporate strategy in this recession economy is to not hire people full-time so that they don't have to pay benefits. We've received funding, as I said, from the Wisconsin Partnership Fund. We've been recognized as a model project for services integration, and we've received some local awards. We've also done qualitative surveys with our families, and as you can see, a lot of them said, best doggone thing that happened to me. What they appreciate is, I think, the family support. When we look at the decrease in depression scores, it's finding them a medical home, it's getting them on meds, but it's that ongoing problem-solving support that is available to them, and also bringing them out of the household and reducing isolation. We're finding that they indicate also that they like the advice and information and support, they like the employment and education resources, and they just need somebody to talk to and problem solve with. Again, comments from the clients about how they've been helped by the program. The one thing that's really interesting, I was talking with one of our home visitors, this is all about developing a relationship. I mean, I'm a social worker, it's social work. And so some of it is just how do you have the time to develop that relationship? A lot of it's giving them something that they need. It's having time to spend with them, and we're finding a lot of social workers now, they're just processing people. They're documenting in front of their computer screens, they're in court, they're not in the households. And so the key to the relationship is a positive regard for each other, listening, reframing, and problem solving. And so, this, I think, is a perfect example of where a services integration approach has led to better outcomes. And what we say in this program is you got to have an educational linkage and employment strategy. This approach keeps people connected to MA and insurance. And the other things that we're finding is a lot of persons of color aren't comfortable in traditional mental health settings. I was talking with a guy who had been in prison 5 times 2 weeks ago, and he was saying, I don't want to go there. I want somebody to come out to me in the community, and do the counseling out there. That's where I feel more comfortable. And the other thing we're finding is that there needs to be a broader definition of health. It's just not physical health, but it's emotional and relationship health. And I know a lot of you as therapists, that's what you're focused in on. How's your emotional health and how you're doing in relating to other people? And the other thing is that we're finding that in our siloed approach, given a lot of multiple challenged families coming at us, is that we can't work in silos anymore. We have to have an integrated teaming response to help people. And so this just kind of gives you an idea of we need to get a randomized study in place so that we can really validate our model. And we think that over time what we'll be showing is that we'll be reducing mental health and child protective services usage over the long term. In fact, we've been able to keep people out of our child abuse CPS unit because they know we're in the community and we're with that family and we're monitoring them on a daily basis. So that is it. That's the presentation. Okay, so I'm open for questions if you'd like. I was talking with my counterpart Andy, and I think, one of the big questions is if you want to try to do a collaborative approach, a teaming approach, given where you're sitting, how do you do that? I mean, where do you start, particularly if you don't have a funding grant?
Has this program or something similar to it replicated in more rural areas of the state?
No, we're still based in Madison, but I think, I do another collaborative approach that involves community social workers, police officers, public health nurses and stuff. And so the issue in the rural areas are that you don't have that concentration of families to community base with. And so that approach really is a kind of a professional networking model where you know each other and you meet together to work families. And then within Madison, we have a lot of rural areas, and transportation is a major barrier. And what I'm saying is you have to have cross-system teams that are mobile. They move around, and they go to libraries, and they're in quadrants so that people can get access to those services. So the rural model is going to be a different approach. Because one of the things you want to try to prevent is having your professionals spend a lot of time in their cars driving and not be with families. So. Got someone over here.
This is sort of a procedural question. How do you enroll families in your program?
Well, what happens is a lot of it, first it started with professionals referring to us, like from hospitals or public health nurses. And then what happens is other families see the benefit of the program, they self-refer. They self-refer other families. Now what we found, though, is that we were engaging families and meeting with them one time and starting to do all of our family plans and stuff, and we'd lose a lot of those families. So we don't really think that we have a family until we've met with them 3 times, and we have some engagement. We have to meet with them 3 times and see some response on their end before we say that they're in the program.
I would just like to bounce your question back to you. You mentioned, where do you start? What are your recommendations?
Well, I think that what you need to be thinking about when you're interfacing, are you a mental health therapist or a philosophical? Okay. Well, I think, one of the dimensions that you have to think about when you're interfacing with somebody is what's in their environment that's causing them stress, that's, exacerbating their mental health challenges. Well, with low-income people, a lot of that is I need a job, I'm going to bomb out of my housing, there's a lot of domestic violence in the household and things like that. So what you should do is to figure out what are the issues that are confronting your families and then pick the professionals out that deal with that issue and convene a meeting and start to do the relationship building that's necessary to maybe to start work families together. Now, the confidentiality issue is if you have the trust of your client, sometimes you can just do a release of information form. I mean, when they come into the ECI program, when we have the trust, we have them fill out a form that allows us to share information with other providers. And then to maintain trust, you're actually doing stuff to really help them, on that environmental agenda. You're helping them, somebody's helping them find a job, somebody's keeping them stable in the housing. It's all about relationship. And so it's really identifying the players in your community that deal with those issues. I want to also say another thing about being community-based. In my initiative, we have linkages to 177 churches because we get a lot of valuable resources off of them. And we've even had communities develop resource area needs networks. So like in DeForest, Wisconsin, churches, businesses, private citizens put $40,000 to $50,000 on the table a year that my social worker has access to. He screens them, makes sure they're connected to all the safety net benefits, but then there's money to help stabilize the family. So there's these localized resource clusters that have formed based on those relationships.
Could you speak more to the Wisconsin Partnership Fund?
Shell could do that too. It's Blue Cross Blue Shield money, and basically they have an ongoing application process where you can apply for planning grants to actually plan to implement an approach. And then they have other grants to actually implement the approach. So we did a planning grant, and then we got a $450,000 over 3 years. And then since we had success, they extended us another 3 years. So if you approach me after this session, I can give you my card and I can link you to them, or send it to the coordinator of this conference and get it out all to you. I'd go for that.
Okay. Hi, Ryan.
Hi.
First of all, I want to thank you. I'm from Dane County originally, up till 6 months ago, relocated, and I know how much you've done in the Dane County area. In relation to this program, I was curious to know how that program evolved from what the work you were doing, how you identified the need there, because I do believe, as a clinical social worker myself, as a therapist, play multiple roles for the UW now here in Wausau. But is that, I'm kind of trying to figure out how to get the key players on board.
First,
how do I outreach? How do I get them to?
Well, the easiest way would be to find a political champion. The way it started there was Kathleen Falk came to me and said, listen, I want to do something from children, youth, and families. I want it to be empirically based. So I did this full-scope literature review that about killed me. It was across the age continuum of what's out there for children, youth, and families. And we focused in on home visitation.
Yes, I remember that program.
Yeah, so it was one of the few approaches that had been empirically tested, and then we said, well, there's a missing component. So we added the employment component, we added the job center component. And we did focus groups around the community with both professional stakeholders and residents and other people. And then we engaged our local foundation. They gave us $50,000. It wasn't as easy as the political leader saying, here's the money. It was like, okay, you'll find the money. And so it's kind of trying to find a best practice model, demonstrate the need, and then engage people that have the money and foundations and get some political buy-in.
I work in the employment and training here.
Okay.
I work in the employment and training field. I work in a job center in northern Wisconsin. And many of the job centers around the state of Wisconsin offer free workshops for pre-employment training, pre-employment skills. We are a great resource. You're talking about low-income populations, and we have the internet, and we have access to job search and labor market information to assist people too.
Yeah, and so it's engaging your local job centers. I mean, what we're finding on the employment agenda is that first, the depression, DV, AO to mental health is a significant barrier beyond the educational deficits. But we're finding three populations. We're finding a light touch population. Here's how you fill out an application. Here's how you deal with your interview. Here's your job targets, go. Then there's another component where they really do need individual support, ongoing, and counseling and encouragement. And that was a missing part in our continuum because job center workers are severely stressed with high caseloads. And then there's this really vulnerable population that is never attached to the workforce, and that's where the employment specialists come in. They're full-time working the whole family. So we got to be more sophisticated about our approach to employment response.
Hello.
Hi.
Good morning. Joan Toyer, and I work with Marathon County Health Department. And I just wanted to comment because I think people in the room may not be aware of a resource that we have here in Marathon County, and that's called the Start Right program. And it parallels similar to what you described in terms of a partnership program between the Health Department, Children's Service Society of Wisconsin, as well as the Department of Social Services, and really providing that system of support and education for families prenatal up until kindergarten. The one thing I was struck by your presentation, and I think it's a conversation for us to have as a community in terms of how do we strengthen particularly the employment education component of what we do, because that's a little soft. I think we recognize the need for it. And I think the other opportunity, which we did have a pilot project for a few years looking at postpartum depression, and like what you indicated, we saw the same thing in terms of the marked increase of postpartum depression. So how can we create some alternative models in terms of ensuring that women and families receive the social emotional support they need?
One twist we did on our employment response is we set it up to where there was post-job placement, case management support, and tight linkages to the employers so that as soon as something came up, we were right there. And we go to employers, say, take a chance on this person. And so there were times where we had a guy, he was an LTE janitor for the county, and he hadn't showed up for a day. So we went out looking for this guy, saying, you're going to lose your job, you got to get back there. So I think there has to be some support for employers, to take these risks, and there has to be some post-job placement case management in place also.
Could you touch on, you touched on increasing poverty and homelessness. The support you have for homelessness in Madison, is it church-based? What funding do you have, et cetera?
Well, we have a traditional shelter system, that has a limitation on slots. We're encountering, but a lot of communities are encountering, the housing foreclosure crisis has moved a lot of people that were in homes and that they owned into rental stock. So it's very hard for people who have criminal records and bad credit to get in now. One of the things that we've done is in a number of our sites we have housing case managers. So we have ongoing relationships with landlords, and we use our relationships to get people into housing stock. But it's a problem. We have a lot of problems with homelessness. And I was sharing with somebody today, there's a book called What the Dog Saw by Malcolm Gladwell. He wrote Tipping Point, and basically this guy went into a homeless shelter in Nevada, I think it was. He analyzed the homeless population. Well, he found a lot of people, it's just short-term episodic. But then he got to the chronic users. Chronic alcoholics that were hitting emergency rooms like 15 times a month, and then they put cost figures on it. It was some of these people costing $150,000, $175,000 a year. So what they said is it's cheaper to give them an apartment and then give them case management and then transition them out than letting them be on the streets. And when I think about this collaboration and how we get this all together, again, I think it's attaching cost to cases, because when people see how much some of these families are costing us, some of these families are $1 million families. When you take every member of their family and you take intergenerational system involvement. And so how do we be more effective to break that cycle?
How much of the interventions were due to like larger group or community-wide problems and addressing those versus addressing more individual problems? And my second question would be, how would you apply this to populations that are better off? Like, how would you imagine doing that? Like, maybe internet stuff, trying to get a handle on the population of people that are doing better, and then using internet interventions and things like that. Because, obviously these people didn't have computers and all that. So those are two questions, yeah. Okay.
First question is, what are we doing on a macro level or community level to improve outcomes in community environments? Well, since we're community-based, we can link in with churches and other local actors and get some alignment of effort within neighborhoods. Since we work in networks, we hold each other accountable. We know when somebody's not really working with families and doing a good job with them. And also, we're able to see when families come into crisis and get to them more quickly because we have a relationship and we're right there. So one example of a macro level intervention, worst community in Madison now is Southwest Madison. Mostly single parent families with no extended family networks, large families. So a church approached us. They had done a fundraiser to add on to their building. They had $150,000 left over. So they solicited grants from the community. We got one. We got the grant. And it's going to be a housing stability approach where we have a housing resource center in the neighborhood, and we have this quick early intervention response when families come to trouble to keep them stable. So that's kind of one example, because the new paradigm really is mobilizing resources from the community. And we have an approach, time banking, where we're linking people together to exchange resources and skills, neighbor-to-neighbor approach. We screen them, we do background checks and all of that. And so now we have, like a kid will mow somebody's lawn and be able to participate in a sports program. We have people that are bedridden that can call other people and have them, remind them to take their meds. So it's those neighborhood approaches that, and with technology, I think a lot of it's, the transportation barrier is huge. Can we have interviews with people in Skype so we don't have to travel out there? A lot of people still don't know how to use computers though. But I think technology can yield some positive results for us. Email. I mean, I've got networks of workers that they come up with a family situation, they pop it out on the email and they say, okay, I got this, what do I do? And people, say, okay, well, try this, try that. So there are some technology things I think we can do to improve our interventions. Okay.
That's all we have time for.
Right.
So.
Okay, we'd like to...
Drop the table here.
Sure, move that. That's my job.